Hello, my name is Brandy, and I want to warmly welcome you as part of the Mana family. By now, you have likely spent the past 2 weeks performing assumption of care assessments and admitting new patients in your building. While you may not have completed all of these tasks yet, you've probably begun to familiarize yourself with the facility, many of the patients, and hopefully some of the key team members, such as the Director of Nursing, unit managers, and other support staff, though it can be challenging to connect with everyone on the weekends. You may have also met some of the physicians and advanced practice providers, including nurse practitioners and physician's assistants, who round in the facility. Additionally, you might have interacted with a wound care physician, the psychiatric mental health nurse practitioner, or other supportive clinicians. However, some weekday physicians, administrative staff, and extenders may not yet be familiar to you, as they primarily work Monday through Friday. This educational program has been designed specifically for weekend nurse practitioners. It will guide you in identifying which patients require priority evaluation and care during your shifts. In a typical 120-bed facility, it is not uncommon for each weekend to involve over 20 patient visits a day. Your role as a weekend nurse practitioner is a critical extension of the weekday clinical team. Weekends are often marked by reduced administrative staff availability, an increased risk for falls, and potential patient declines. Your contributions are vital, not only in supporting the overall health of the Aspire facility and the Mana team, but also ensuring the best possible outcomes for the patients we serve. Your ability to prevent rehospitalizations, detect patient decline, and address critical labs enhances the quality of care and underscores the importance of your role. Thank you for your dedication and welcome to this essential position. We will be conducting a review of how to navigate point-click care to assess the necessary reports and daily visits required for the weekend nurse practitioner role. This will include a review of all changes in patient conditions and assess high-risk patients. This includes those receiving new antibiotic therapies, patients who have experienced recent falls, individuals with risk management concerns, new physician orders, and patients with newly identified wounds. The first task of the day is to make rounds with each nurse in the building. Inform them that you are available for any patient concerns and inquire about any changes in condition or patients requiring evaluation. You will then conduct assessments for all new admissions and readmissions that have occurred within the past 3 days. For patients who were assessed the previous day, conduct follow-up evaluations to confirm that there are no new concerns and that the patient remains stable. For patients who have not yet been seen, review their chart thoroughly and perform a complete evaluation and assessment. This process is critical, particularly for medication reconciliation, to ensure that all medications are appropriately dosed, correctly aligned with diagnoses, and that any required stop dates are documented in point-click care under physician orders. During this time, also verify that any referrals to specialists have been documented as orders in point-click care, so the nursing staff can follow up on scheduling appointments. Additionally, review and ensure that wound care orders and other miscellaneous orders are properly documented and placed in point-click care. A helpful practice is to print face sheets for each new admission. The face sheet provides valuable information such as marital status, religion, primary diagnosis, and emergency contact details. Contact information is particularly important when a patient is not alert and oriented, allowing you to communicate care plans with the power of attorney or healthcare surrogate. The face sheet can also serve as a convenient tool for taking notes on the patient during your assessments. Once you have completed the assessments for new admissions and readmissions, proceed to the laboratory section in point-click care to review any pending results. For patients with lab results requiring attention, conduct an evaluation and initiate appropriate interventions as necessary. After reviewing the labs, document your review by marking the results as reviewed and closing them in the system. For any patients with abnormal lab findings, ensure that new orders are entered into point-click care as indicated. Additionally, schedule follow-up laboratory tests to monitor the effectiveness of your initiated intervention and ensure that the patient's condition is improving. Next, proceed to the risk management section, where you will review all incidents involving new falls, newly identified skin issues, abnormal behaviors, and resident-to-resident altercations. Each of these patients must undergo a thorough evaluation with the issue documented in the history of present illness, the HPI section. Additionally, ensure that an appropriate intervention is included as part of your assessment and plan to address the identified problem. Assessing the 72-hour report is a critical step as it provides a comprehensive snapshot of each patient's status and any significant occurrences documented by nursing, therapy, dietary, or other healthcare providers. This report allows you to identify abnormal vital signs, documentation indicating a change in condition, and any other abnormalities the patient may be experiencing. Finally, at the bottom of your dashboard, review the list of patients currently on antibiotics, as well as those who have recently started or had adjustments to psychotropic medications. While it is not necessary to assess all these patients during the weekend, their status should be reviewed in collaboration with the nurse to ensure there are no concerns or complications related to antibiotic therapy or changes in psychotropic medications. This page provides guidance on locating admissions, discharges, and transfers. We call that the ADT, allowing you to filter by a date range of 3 to 7 days. It is essential to prioritize evaluating new admissions from the past 1 to 2 days to ensure they are adjusting well and to address any potential issues related to medications, stop dates, diagnosis, or lab orders associated with each medication. For example, a patient with hypothyroidism should have a baseline TSH level obtained, and a patient prescribed a statin should have baseline labs such as a lipid panel, CRP, and sedimentation rate. These are just illustrative examples. You can further note any other labs. For patients not yet assessed, it is crucial to conduct a thorough review of discharge records and the medication list entered by the nursing staff. Verify that all medications are linked to the correct diagnosis in point-click care. For instance, if a patient is prescribed Eliquis and the diagnosis is anticoagulation, ensure that the diagnosis in point-click care is corrected to atrial fibrillation or DVT or whatever is appropriate. Similarly, if aspirin is prescribed, the associated diagnosis should be coronary artery disease rather than a generic or incorrect entry like supplement. This page provides a step-by-step guide on how to review lab results each morning in point-click care. After reviewing the results, you will assess whether any interventions are needed and if follow-up labs should be ordered. All orders must be documented in point-click care. For any abnormal lab results requiring intervention, a patient assessment must be conducted. The chief complaint should reflect the clinical issue related to the abnormal lab result, rather than simply listing lab review under chief complaint. For instance, if a TSH level of 10 is noted, the chief complaint would be hypothyroidism. Similarly, if hemoglobin is 7.5, the chief complaint could be anemia. These are just illustrative examples. Once the lab results have been reviewed and necessary actions have been taken, click the Mark as Reviewed tab. The lab results will then appear in the patient's chart under the lab section with your name and the review date clearly noted. Please note that labs should be reviewed daily. Any abnormal results that are not noted for multiple days to review and address with interventions may be considered a delay in care, which could present significant issues to the patient in the event of litigation or on an ACA review. This page outlines how to navigate the Risk Management tab in Point-Click Care. Ensure you are under the Active Incidents section and scroll to the bottom to view the most recent incidents. This will provide information on falls, skin, new behavioral concerns, and other significant patient issues. It is crucial for weekend nurse practitioners to document and address any incidents that occur on Friday, Saturday, and Sunday, as these are issues that cannot wait until Monday to be addressed. Although some facilities may have weekday nurse practitioners and administrative staff available to assist, any risk-related incident must be documented by a provider with an intervention as soon as possible. For example, a patient who falls on Friday evening may not be evaluated by the nurse practitioner or nursing management until Monday. However, by assessing the patient on Saturday, you can determine the cause of fall, check for injuries or neurological changes, and implement interventions to rule out underlying causes. Do not wait for nurse management to start a bowel and bladder protocol if the fall occurred during toileting. Additionally, review the patient's medications, vital signs, and recent lab results. Check the blood pressure to ensure it is stable and the heart rate to rule out irregularities or bradycardia. If recent labs have not been ordered and the patient is showing signs of increased confusion, it may be prudent to order labs to rule out infection, electrolyte imbalances, or thyroid dysfunction. If the patient shows symptoms of a urinary tract infection, obtaining a urinalysis on Saturday will provide results by Monday or Tuesday, enabling timely interventions rather than waiting for the weekday nurse practitioner to assess the patient. When documenting falls, it is important to remember that the documentation will be reviewed not only by your peers, nursing staff, and administration, but could also potentially be scrutinized in a litigation scenario or an ACA review, depending on the fall's severity. Start your note by documenting what you know about the fall based on the nursing report or information in the Risk Management tab. For example, in quotations, nursing reports patient was found on the floor on the left side with no injuries noted. Patient was assisted back to bed and the call light was placed within reach, end quote. Even if nursing did not report this directly to you, you will reiterate the information documented in Point-Click Care by the nursing staff. Next, document your own observations. For example, patient was in the room and a full assessment was completed to rule out injuries or abnormalities related to fall. There are 3 key elements to include in your documentation. First is a skin assessment. Document any skin injuries such as bruising, bleeding, or lacerations. For instance, in quotes, patient has a laceration to the left hand, which is covered with steri strips. No active bleeding noted. Peri-bruising observed around the laceration. No other skin issues noted, end quote. Or it could be patient without any symptoms of bruising or bleeding, no open wounds noted. Number 2, skeletal assessment. Document any musculoskeletal abnormalities. For example, range of motion within normal limits. If the patient has a history of conditions such as a CVA with hemiparesis or hemiplegia, paraplegia, or contractures, you might note range of motion within normal limits for patient. Document any deformities, pain complaints, or abnormal findings such as internal rotation. Include any interventions like X-rays or Doppler studies if necessary. Number 3, cognitive assessment. Document the patient's mental status. For example, in quotes, patient is alert and oriented at baseline, but unable to recall how they fell, presenting with confusion. If the patient has baseline cognitive impairment, document, in quotes, patient is unable to recall how they fell, but is confused at baseline, end quotes. This is how we determine if a patient needs to be evaluated in the emergency room for a neurological deficit. Under your assessment and plan, be sure to note a discussion with the facility staff regarding fall prevention strategies, including completing a medication review and vital sign assessment. Include any additional interventions or recommendations in this section. Lastly, if the patient is on anticoagulation therapy, it is crucial to discuss with the physician whether the patient will continue or discontinue the anticoagulation. A thorough discussion with the physician is necessary to assess the risks versus benefits and make an informed decision. You do not want to be the nurse practitioner who continues an anticoagulant, the patient falls again, and then ends up with a subdural hematoma. You also don't want to be the nurse practitioner responsible for discontinuing an anticoagulant and having the patient end up with a stroke or going into atrial fibrillation again. Allow the doctor to make that decision. One of the key responsibilities of the weekend nurse practitioner is to review new admissions and conduct an admission assessment. Each note should begin with the patient's age, sex, and one primary diagnosis. Avoid listing multiple diagnoses in this section, as the past medical history will capture all relevant diagnoses. Admission notes must include the reason for the patient's hospitalization, any significant findings, the need for skilled nursing facility placement, and any follow-up needs while in the skilled nursing facility. This should be summarized in a concise 4 to 5 sentence paragraph at the beginning of your history of present illness, your HPI. For long-term care patients, if you are assuming care for a patient that you have not previously seen, include a brief statement explaining the reason for their long-term care. This might involve cognitive impairment, dementia, lack of family support, or requiring more assistance than the family can provide. This should also appear at the top of the HPI. The next section of your HPI should detail the patient's current status. If this is an acute issue, you will follow the old CARTS format for the chief complaint, describing the symptoms in detail based on the patient's report. Highlight what worsens or alleviates the symptoms, including specific actions or circumstances. Document any associated symptoms that provide context to the chief complaint. Be sure to include pertinent history or background that supports the current symptoms and summarize any additional relevant information. For patients stabilized post-hospitalization, summarize the patient's status after discharge, documenting the review of medications and the patient's response to them. Include any concerns or questions reported by the patient, family, nursing, or other staff. Since we no longer use a formal review of systems, document any pertinent negatives related to the chief complaint. For example, if the patient was admitted post-pneumonia, you would want to document in your HPI that the patient denies any chest pain, shortness of breath, or dyspnea, that their O2 saturations were stable, and that their lungs were clear to auscultation. That's just one example. All infections should be thoroughly documented at the initiation of antibiotic therapy. For any patient started on antibiotic therapy over the weekend, a comprehensive assessment must be completed. Begin by documenting the patient's symptoms and the location of the infection. For example, If the patient has a urinary tract infection, include any genitourinary symptoms. For infections such as cellulitis, provide a detailed description of any erythema, warmth, or edema. When initiating antibiotics, discuss potential GI side effects with the patient, including potential for nausea, vomiting, and diarrhea. It is also advisable to start a probiotic to reduce the risk of C. diff infection. For patients who complete antibiotic therapy over the weekend, ensure documentation reflects the resolution of symptoms or the completion of treatment. Include any side effects the patient may have experienced, and if no side effects are reported, document this as well. The final and most critical aspect of any patient visit is confirming the payer source to ensure reimbursement for services rendered. It is important to understand that each patient typically has two distinct payers, one for the facility and one for the provider. On the census line, you will see the facility payer listed. This could be Medicare, hospice, Medicaid pending, or straight Medicaid, indicating the payment source for the facility. To verify the provider's payer source, open the face sheet and check for a Medicare beneficiary ID number. This number follows a specific format, a combination of letters and numbers. The Medicare beneficiary identification number determines whether the nurse practitioner and other providers are reimbursed through Medicare. Guidelines by payer type. Medicare A. If the census line lists Medicare, you do not need to go into the face sheet to look for the Medicare beneficiary number. These patients can be seen 3 times a week and for all changes of condition. Long-term care patients with Medicaid, you're going to want to open the face sheet and check for a Medicare number. Patients with Medicare may be seen as needed without limit, including wounds, weight loss, falls, or changes of condition. If the patient has Medicaid without Medicare, they are limited to 1 visit per month, typically handled by the weekday nurse practitioner. Avoid seeing these patients unless intervention is necessary to prevent rehospitalization. HMO or PPO, those patients can be seen as needed for changes in condition. Hospice patients, verify the patient is on hospice. You are permitted 1 visit per month unless there is an emergency. Typically, this is performed by the full-time nurse practitioner. Avoid these visits unless the patient is having a significant change and requires a visit. Medicaid pending patients. Verify if the patient is a Medicare beneficiary. These patients may have had Medicare for an initial 100 days of care before transitioning to Medicaid pending for the facility payer. If Medicare is still listed on their face sheet and their Medicaid pending, you can still see the patients. They still have Medicare, and that's what the nurse practitioner gets paid from. County-funded Medicaid, county-funded or special cases such as Hillsborough County or Tampa General. Patients with these designations lack a payer source for providers. The hospital pays the facility for the patient's care, but there is no reimbursement for provider services. Do not see those patients.